So what I did is I looked at the data, actually, individual data, and all the papers that were published to that time, 2008, and I tried to see what was the evidence there that was prolongation of the QTC, and how many studies reported prolongation of the QTC over 500 milliseconds, because 500 milliseconds is the critical cutoff for torsade de pointes. So what I found, actually, as you can see, that there was one series here that showed two above 500 milligrams, but this is a cross-sectional study, okay? So this is not a prospective study, cross-sectional study, and they found two. So if you look, for example, to my paper here that we published with some people here in 2005, so we didn't see any, 0 over 500, right? So it was a cross-sectional study. So at that point, doing cross-sectional studies is the year 2005. So we started in the year 2002. It took to us 3 years to collect data on 104 patients. It was justified because the scare and the people that are looking into that started in the year 2000, right? So that was okay. Now, would I do that survey now? Would I look at cross-sectional study now on the same issue? I wouldn't do it now because we have more data that are helping us to understand this. Now, why do you think that the cross-sectional study probably it was not the best way to go? Even though, it helped us to understand the patient population, but it's not ideal. Why not? Well, the reason is because if it is true that methadone is causing cardiac toxicity, and that patients are going to have prolongation of the QTC, and they get at risk of an arrhythmia, and eventually they go into an arrhythmia, and then they die, by the time that you do the cross-sectional study with the patients that come to your clinic for a follow-up visit, the dead patients usually don't show up. So you are missing that piece of the information. So that's why this is good. It helps us to know what is the proportion of patients that may have a prolongation of the QTC, but not those that are at real risk, because those are either already underground or they are in the ICU. So it's a good study. It helps you to have a sense where you are, but obviously you are missing critical information. So if you go down this column here, then you are going to see what is the level of evidence for this, and you get prospective, so several prospective studies. Some of them have, 41 patients, 132, 108. So the quality of this is better because it's prospective, and but no one really saw a prolongation above 500 milliseconds. Then you have the cross-sectional studies. One of the cross-sectionals reported 2. And then you have a bunch of other studies. There is only one double-blind study, which is this one done here. And these guys, what they saw actually is one prolongation over 500 on an N of 78 patients. So that's very interesting. It really makes you think what's going on, and you have just to be careful. So this is again going on the people that saw a prolongation of the QTC. So it depends on how you look at the data and the level of evidence that you look at that you are going to get an answer on another. The problem is that, as I said before, there is only one double-blind study, which now probably the IRB of any institution would not approve, because we are worried now about that. So I still don't understand how they managed to get it through their IRB. But the bottom line is that it went through. And this is a different level of evidence. What we are listing here are case series and case reports, right? So these 17 patients, and then 3, 4, 1, 1, etc., etc. The one on top, 17 patients, is the one by Maury Krantz that I mentioned before, 2002, which is what started raising the concern about the torsade de pointes issue. So this is one way to look at the literature and to define the question. Then I'm just going to, since we don't have that much time left, I'm going to go to another aspect, which is the palliative care issue. And again, you have to ask the right question in palliative care as well. And the question, in my view, that got me excited about this was fatigue. And the reason is because of the high prevalence. If you look at patients that have about a couple of months left of expectancy, you get fatigue that is above pain as one of the complaints that patients have. So it's a very relevant issue to take a look at. And fatigue, the other reason why I like it is because it is very, very complex. And why do I say that it's complex? Because you can have many, many different conditions that actually can have an impact on it. So depression can have an impact, cachexia is going to have an impact, metabolic abnormalities, anemia, autonomic failure, hypoxia, endocrine abnormalities, drug-induced side effects, deconditioning, right? The cytokines we know now that have an impact on it. Pre-existing conditions, pain, dehydration, infection, radiation therapy is a big one, chemotherapy also, anxiety and depression. So all this will have an impact on fatigue. So it is a symptom that is very, very difficult to study. And not only that you have all these aspects having an impact on it, but there is some interaction in between them. And this could be an example. Pain has an impact on depression. 50% of the patients on chronic pain are depressed, and we are saying that depression has an impact on fatigue, and pain itself has an impact on fatigue. And then we know that anxiety, 50% of the patients that have depression have anxiety as well. And then we know that radiation therapy can cause anemia, and then we know that cachexia can cause depression, and that drug-induced side effects and anemia are related. Endocrine abnormalities can cause depression as well, and the infection will release cytokines, and cytokines will cause fatigue, and chemotherapy will cause anemia, and then cytokines are going to have an impact on cachexia and depression, as we well know, and the metabolic abnormalities will have anemia and cachexia and depression. And that happens when you don't take your lithium in the morning. You go totally crazy. But the bottom line is that is very complex. So chances that you are going to be able to answer a question when you look just at one of these factors sometimes is difficult. And the reason is the other factors are going to be progressing, are going to be fluctuating depending on what is the situation of the patient. So, but it is a worth way to look at the literature. So I said, what is the role of fatigue on these patients? Can we do something about it? And one aspect that I found interesting is the metabolic aspect of the cell. And so normally what you do is you get your energy from glucose. That's what we normally do. So if you had breakfast, what you did is you replenish the glucose that you used overnight from your liver. It was in the form of glycogen. So it is a release of glucose that goes into the mitochondrium to the Krebs cycle, and you produce ATP, and the ATP gives you the energy. Now another source is the amino acids. We don't want to use that source of energy because they are structural proteins, so you want to preserve them. But still, if you don't have enough glucose and you don't have enough fatty acids, eventually you are going to use the amino acids that you want to protect. So how can you protect this, and what is the most efficient way to do it? Well, what you use for energy is long-chain fatty acids that go into beta oxidation in the mitochondrion, and then the products will go to the Krebs cycle producing more ATP. Now, the issue with the long-chain fatty acids is that they don't cross the membrane well. Short-term and intermediate chain fatty acids, they do cross. Long-chain fatty acids have difficulties. They need a carrier, they need help, and the help is carnitine. So what is interesting is that patients with chronic illness, carnitine might be deficient, might be low. So you may have the fatty acids, but you cannot use them. So the question here then is what happens with patients that are in palliative care or hospice. What is the carnitine levels? Can we help their fatigue by supplementing carnitine, by facilitating the long-chain fatty acids on crossing the membrane, going into beta oxidation, producing ATP, then having the products of the beta oxidation going in the Krebs cycle and producing more ATP. So that was the question. And what we did in the year 2004 was to start looking at the basics of this question, because there was not much out there. So what we decided to do is to do we didn't do a randomized clinical trial. We didn't even know the dose, so that could be helpful for the patient. So what we did is something different. What we did is a design that is called a dose-finding design. So we got patients here at the beginning. We did a Karnofsky, BFI, other type of tools to determine what was the level of activity and fatigue of the patient. And then we got 3 patients on this dose, completed this, then 3 patients on the following dose, and so forth, and tried to find out what was the dose that we needed on the patient to feel better. And then what we found is that fatigue was improved, as you can see here, in a significant manner. Depression was also improved, and sleep quality was also improved. And we defined that 2 grams a day, between 2 grams a day and 3 grams a day, was a decent dose to treat patients to have an impact on fatigue. Hello, how are you?